Welcome friends to EPG Patashala. I am Dr. N. Janardana, working as faculty in the Department of Psychiatric Social Work, NEMANS, Bengaluru. So today we will have a continuation of mental health problems seen in children. In the previous module we have discussed about the developmental disorder. In this module we will discuss about the internalizing mental health problems, externalizing mental health problems seen in children, and other adult type of mental health disorders seen in children, and miscellaneous disorders which cannot be grouped under all these categories have been discussed. So we would start with opposition defiant disorder and then go with the conduct disorders and how these disorders need to be identified and what interventions need to be provided would be covered. And then we'll look at depression in children, how children do experience depressive symptoms. And then we will look in terms of various types of mental health, other mental health problems children would experience. Now let us understand the externalizing behavioral problems in children. Under the externalizing behavioral problems in children, first we find opposition defiant disorder, where children with opposition defiant disorder display a great deal of aggression, purposefully annoying others, showing deviance persistently, negativistic, disobedient, and have trouble with authority figure. We would have seen children who are we would term them as a naughty child, but naughty up to certain level is acceptable. When it crosses beyond that certain level, then the child would have problems in terms of maintaining interpersonal relationship, and they would be purposefully annoying others, and they would enjoy by annoying others. The action of these children seriously interfere with their functioning at home and at the school, and in the school they will be termed as a bad child, and often repeated complaints would be given back to the parents, and parents also would find it difficult in terms of dealing not only at home but also answering at the school authorities. So this is one of the conditions which need to be handled. Children with oppositional defiant disorder exhibit a pattern of these behaviors beyond age 3 and throughout their adolescent years. So clinical description or symptoms of ODD include refusing to comply with the adult request, lying, not giving respect to adults, irritating others intentionally, exhibiting sudden unprovoked anger, blaming others for their mistake or for their misbehavior, bunking from school. Where the child would have problem in terms of abiding to the adult request and or complying with the school rules or the rules at home. So always they will be opposing back to the authority and end up in problems. And parents also would not be in a position to deal with that problem. They also will be always in a helpless situation. So as part of ODD, we also see a conduct disorder where it's a little severe form of ODD. It refers to a set of problem behavior which may involve the violation of a person, their rights or their property. And the clinical description of symptoms of conduct disorder include being aggressive, destructive behavior, deceitful behavior, and violation of rules. Many children with conduct disorders are irritable, have low self-esteem, and tend to throw frequent temper tantrums. Some may abuse even drugs and alcohol. Causes of ODD and CD, it's a combination of again biological, genetic, and environmental, psychological, dysfunction, family life, child abuse, traumatic experience, and family history of substance use, and inconsistent discipline by parents and social factors play a major role as a cause for the ODD and CD. Children would have picked up many of the behaviors from the parental interaction, the way the parent provide the parenting. The inconsistency in disciplining the parent. When a child has been misbehaving, the parent would not pay attention towards it and may not show a disciplinary action. Suddenly the similar behavior, when it has been done next or a third or fourth time, the parent would show an action where again there will be a difference between the father's reaction and mother's reaction. For mother it is not okay, for father it is okay. When such inconsistency happens, the child will get confused what is right or what is wrong, and then child would start performing behavior which would irritate others. Treatment include individual psychotherapy, where helping the child to learn to express and control anger in more appropriate ways. So child need to recognize anger is one sort of emotion, and that emotion need to be expressed in a more acceptable way, rather than throwing temper tantrums or rather than throwing anger outburst on others, which is going to damage others, and their relationship would get damaged. That need to be we need to help the child to understand as part of our supportive intervention towards the child. Then cognitive behavioral therapy again aims to reshape child's thinking, to improve problem solving skills and anger management. So child need to be helped by the mother would react in such a way back to her, so that when the child is able to understand, the relationship also get improved. So parent management training is one of the important intervention under behavioral management, where the parents need to be trained about increasing acceptable child behavior. There are many behaviors of the children which are not acceptable, so help the parent. So what they need to encourage, what they need to ignore. Give clear and simple instruction to the child, so the child is able to understand, not to be inconsistent between parents. Reducing unacceptable behavior. Time out from positive reinforcements. So time out is not just should not be viewed as a punishment. It can be when a child is eligible, or when a child demands certain things. So it can be linked up, okay, if you able to perform this, so you are able to get this. When a child is not able to perform to the accepted terms and condition, then the child need to be explained that the reinforcement what was supposed to be given to you would be withdrawn for a temporary period of time. Setting limits is another intervention which we need to teach parents. Parents need to acknowledge the feeling, communicate the limit, target alternatives. Child should be explained it is not okay to raise hand towards the parent. Hands need to be held down by the parent, and eye to eye contact need to be established, and child should be communicated it is not acceptable that you use your physical energy back on me. Such limits need to be established and need to be communicated to the child, so the child also understand it's not okay for me to beat my either father or mother. It's not at all acceptable. That need to be communicated, and the limits need to be set for the child. Sometimes we would have seen a child throwing temper tantrums, just falling themselves and demanding that this need to be bought for me, and it's not acceptable for a child that giving reason for not buying. The child should be communicated clearly that this is not possible, and it cannot be done like bought at this time. Maybe later stage it can be done. At this particular time, like it's not possible, and the child should be informed, so the child would understand and would not throw temper tantrums. And sometimes temper tantrums need to be ignored. The ignorance, once we ignore the temper tantrum, child also will understand that this is not going to work out with my parents. I may have to look at a different strategy of my communication and get things from my parents. So the internalizing problem in children is a depression in children, where an illness when the feeling of sadness persistent and interference with the child or an adolescent ability to function normally. Children also do experience the depressive symptoms as that of an adult, and sometimes the depression is more seen in adolescents. The prevalence of depression in children, as per the studies, indicate that 3 to 8% of the children at any given point of time would experience depression. Symptoms would be decreased interest in activities or inability to enjoy favorite hobbies, poor performance in school or frequent absence, poor concentration, withdrawal from family, friends, persistent boredom, low energy, frequent sadness, fearfulness, then tearfulness also, frequent complaints of physical illness such as headache and stomach ache, a major change in eating and sleeping patterns, low self-esteem and guilt, increased irritability, anger or hostility, thoughts or expression of suicide or self-destructive behavior. So all these are some of the common symptoms seen in children who are experiencing depression. Now let us learn about the management of depression, where it can be early diagnosis and treatment are essential for depressed children. So comprehensive treatment again include both pharmacotherapy and the psychosocial intervention, which can be in the form of an individual psychotherapy. For young children aged between 12 and 8 with very severe depression who have thoughts about suicide or have attempted suicide, healthcare professionals may consider a treatment called electroconvulsive therapy, ECT, can be tried out for children who are having a severe form of depression. Otherwise, supportive interventions would play a major role in helping the children to understand the depression. Antidepressant medicine and supportive interventions together can help the child to overcome the depression and lead a normal life either at the family context or at the school context and get back into their academics. So other emotional disorder among children or adolescents are separation anxiety, which is found among young children, where children become extremely anxious and overwhelmed when parents are away. So normally we would have seen children refusing to go to school when they have put into the school, new school, or when the child start the schooling. It's mainly because of the separation anxiety with the parents. They will not feel comfortable at the school level or with the school teacher. So always they would demand that parents would be with them. And this phase would be there for first few 1 week or 2 week when the school being started. Slowly child would gain confidence that it's okay to be away from my mother and be with the teacher and other friends. Child would learn that. There are some children who they may not learn at all. They still would demand even after 3 months or 4 months of schooling. Child would refuse to go to school, always make a scene before school starts, and always demand the mother would need to be with them. They are more anxious in terms of not getting the attention of mother. Various reasons can be for such behavior. It can be like a marital conflict in the couple where a child would feel comfortable being with the mother, or feel that like when I am there, father would not harm the mother. So always demand that I should be with the mother. So that the child would act as a protection for the mother. Child feel that I can protect my mother, and so that I can avoid schooling. Instead of schooling, I'll be with the mother. That is enough for me. So this separation anxiety would be there. We need to understand what is that worrying the child and how to make the child secured, and help the child in terms of understanding that it's okay to be separated from the mother, and mother can be made like protected. And once the child feel confidence, child also would let go mother and concentrate back on the studies. We have phobic anxiety again seen, where child has specific or a persistent anxiety about a particular object, animal or a situation, and child avoids them. Social anxiety, where the presence of a significant fear when the child is encountered with the familiar and unfamiliar people in a social situation. For example, performance anxiety, speaking in stage, singing, participating in competition. It's normal to be anxious before the activity, but the anxiety should not lead the person into trouble and not able to perform at all. Difficulties in talking in public, writing in front of others, always being alone, not participating in extracurricular activities, refusing to go to school, deficit in social skills are some of the other common symptoms we see in social anxiety. Sibling rivalry is another common problem we see in children, where the onset of sibling rivalry is during months of birth of the younger one, usually immediate younger sibling. So when the first child is born to the family, the entire attention would have been given to the first child. When there is an entry of a second child, the first child would feel insecure and feel that mother's attention or father's attention is more towards the younger child than him. So he would lose that attention, and that may lead to form a sibling rivalry, where the child would feel that because of this person's entry, the younger sibling entry, the attention and the love what he was getting from the parents is diminishing, and he may develop hatred towards the younger sibling. So characteristic features of sibling rivalry would be emotional disturbance associated with psychosocial problems, marked competition between siblings for attention and affection of parents, overt hostility, physical trauma and malicious towards sibling, strong reluctance to share, a lack of positive regard and paucity of friends interaction are some of the common things we would see in children who are having sibling rivalry. Other disorders among children and adolescents, which include substance use and behavioral addiction, are also commonly seen among children. We see few adolescents who get into habit of using substances like either nicotine dependency or alcohol use, which lead to dependency at the later stage. And recently we have been seeing young children and adolescents who are involved in behavioral addiction, where they are spending a lot of time, productive time, in terms of using either their mobile phones or being on the internet, playing video games, and googling and exploring things, not able to have a control over their behavior. And they feel craving towards craving always to get into internet and look at various videos or get into social interaction websites and spend a lot of time, and could not have a control over their spending of time and could not stop their craving, whom we term it as behavioral addiction. Then we also see other type of mental health conditions in children, which include psychosis, where children do experience symptoms of schizophrenia and bipolar affective disorder, but the prevalence among children is comparatively less when compared to an adult, and these symptoms need to be recognized and treated. Usually children with an younger onset of these disorders, these illnesses, will have a poor prognosis. The recovery rate is very less. The symptoms need to be treated and need to be put on longer treatment for longer duration of period of time. Maybe lifetime treatment may be required for children who experience schizophrenic or bipolar affective disorder symptom. There are other types of problems children would experience, which can be school refusal, thumb sucking, aneurosis, encopresis, pica, sleep and eating disorders. Other type of problems they would see in children. So in last, let us understand school refusal as an issue in young children. Usually children do not do not learn to express themselves. It's mainly because of language deficiency they would have. An adult who is facing a problem will be able to communicate and extrapolate the problem, whereas a child may not be able to communicate and explain the problem what they are facing, mainly because of the language deficiency. When a child has problem in school, either with his friends because he has been bullied in the school, or a child doesn't feel comfortable with the class teacher, or doesn't feel comfortable the way the maths teacher have been teaching, the child start refusing to go to school. I have seen a client, an very intelligent boy who scores almost 99 point percentage in all his exams throughout in academic career, started avoiding going to school when he was in 10th standard. The reason was that year, for some family reasons, they changed the school for this child. When he went to a new school, he was not able to adjust, and he was bullied by some of his classmates, which made him to stop going to school. And always child used to give reasons for not going to school, and when we talked to him and understood about the traumatic experience he had undergone in the school because of he had been bullied by his classmates, then we had to do a school level of intervention where he was accepted, and we need to talk to his friends, and the bullying part was reduced, where then the child felt comfortable and started going to school. It's not just bullying would have made this child to refuse to go to school. The personality of also would have contributed, where the child because of the low self-esteem and the being an introvert would also have caused this child to refuse to go to school. We also see children having thumb sucking as one of the common problems we see during the childhood. Usually people go like thumb sucking is because of to deal with their insecurity feeling. So that need to be understood and then help the child so that that insecurity feeling can be reduced, and the thumb sucking also can get reduced. Aneurysm and encopresis is another problem. Child should be able to get their toilet training by at least by 5 years. The child should be able to become mastery, where bedwetting is not acceptable behind 5 years. The child need to learn to control their toiletry needs and toiletry needs. Usually we have seen family reasons as one of the like family factors as one of the reason for their bedwetting, where either they would have child would have been experiencing insecurity feeling because of the parental fights, or some other stresses in the family which would have been converted into an amaurosis, that is bedwetting problem. So as part of intervention, we need to educate the family and deal with that emotional atmosphere within the family, so that the fights between the couple can be reduced and child started feeling more secure. And also need to make some arrangements in terms of helping the child in terms of reducing his water content during the night time, and making sure that the child passes urine before getting into the bed. And in some cases we may have to wake up the child in middle of the night and help like instruct the child to pass urine, so that the child will not bedwet. So bedwetting will also impact the self-esteem of the child, and it will lead to other problems. So it's better to identify and treat bedwetting treat bedwetting with a few suggestions, and families need to take up such some actions and help the child to take control over his toiletry needs. Sleep and eating disorders are another common problem we see in children. Some children we have seen like people tend to eat more, and which lead to obesity. And in adolescents particularly, we see like adolescents try to avoid eating food with the worry of being obese, and that can also become a problem. So eating too much and eating too less can be seen under eating disorder problem. Both need to be identified, and then interventions need to be provided so that the eating disorders can be resolved in children. Okay. In conclusion, I would like to say that while working with children, the scope for pharmacological interventions are less, whereas scope for psychosocial interventions are going to be more. Constantly we need to work with the parents, and parent management training is one of the important intervention while we work with the children. So parenting training, parenting skills need to be imbibed in parents, so that they will be able to parent effectively the children, so that the behavioral problems also can be reduced. It's often, most of the time, the children would pick up from their parents. So parents need to alter their behaviors and need to be using discipline when required, and need to be given choices for the children so that they can make decisions for themselves. Once the child is allowed to make decisions for themselves, child will take the responsibility towards their behavior. So this need to be taught to parents. In few decades back, no one talked about parenting training, but now it has become a need of the day, because most of our young parents either working, unable to give adequate attention towards the children, too much pamper their child. I still remember when we were young, getting a watch or getting a cycle, always it was with some achievement, like unless like I clear my 7th standard or 10th standard, I am not eligible to have either a watch or a cycle. But now the affordability of parents have increased. Parents are always waiting when would my son would demand. Even if the son or daughter would not demand, they would try to meet the expectations. What they were not able to get as children, they want everything to be imposed back on children. Like children have been exposed to various classes, whether the child would like or not. Children would be sent to swimming, sent to music, singing classes, in addition to academics. Sometimes children may like, sometimes children may not like. It's, as a parents, we need to identify what are the things my child would like, and then help the child to work on that. And it's good to have extracurricular activities, but not necessary to impose extracurricular activities on the child. Parents need to make such, need to have an understanding what I am being imposing and what the child is liking. Based on that, the child can also enjoy the activity, and parents also feel satisfied. So it's a lot of parent management activities which we need to initiate, and we need to do a lot of school-based intervention while working with the children. Schools need to modify certain things, certain routines in their activities, so that the children can enjoy their schooling and enjoy their childhood. So I have come to the end of this module. In this module, we have understood about, now we have come to the end of the part 2. So in part 1 and part 2, we have discussed about various mental health problems seen among children and adolescents. Part 1 dealt with the developmental disorder, the part 2 dealt with the internalizing and externalizing problems and other mental health problems seen in children, and ended up our presentation looking at the other miscellaneous problems which cannot be grouped under the categories, which include school refusal, thumbs upping, bedwetting, sleep and eating disorders. We also have discussed about various interventions which can be provided for these children, where we understood that pharmacotherapy intervention has a limited role, and lot of psychosocial intervention which include parent management training and school-based interventions which need to be initiated for these children, so that the children would go back to their families, enjoy their family life, at the same time they enjoy their school life which is expected from these children. Thank you all, friends.